Dr. Muralidhar Thondebhavi, yes, who is the consultant in anesthesia and pain management at Apollo Hospital, Bangalore. He'll be joining us soon. I welcome Dr. Muralidhar on behalf of Piezo Kerala State Chapter and on my own personal behalf to this meeting. The third talk is a Ketamine An Old Anaesthetic with New Horizon. When we were studying and practicing, we had ketamine a lot of side effects. But now we started hearing many of the good effects of ketamine, which were widely practiced and is under research. We have Dr. Jithin TM, our own active member from Calicut, who is the consultant anesthesiologist at Baby Memorial Hospital, Calicut. Welcome, Dr. Jithin, to this meeting.
Thank you, sir.
I also welcome our ISA National President-elect, Dr. Venkatagiri, who was behind us for the last 1 year in organizing the team of faculty and in selecting the topics. Welcome, Dr. Giri. Today's webinar coordinators, Dr. Rajesh MC, who is the Scientific Committee Chairman of Piezo Kerala State Chapter, and Dr. Vijesh Venugopal, who is the Governing Council member. We're all actively coordinating this meeting in a much professional way. Welcome, Dr. Rajesh and Dr. Vijesh.
Thank you, sir.
I also welcome our vibrant Honorable Secretary, Dr. Binil Isaac Matthew, who is with us, who is organizing this meeting uninterrupted in a good way. We have two eminent teachers with us, Dr. S. Ramesh from Chennai, who has joined very early with us. Hope we'll be having contributions from his during this talk. Welcome, Ramesh sir. Dr. Anjali Ragesh also has joined us today's meeting. I take this opportunity to welcome Dr. Anjali on my own personal behalf and behalf of Piezo Kerala State Chapter. Once again, I take this opportunity to welcome all the teachers, the delegates, and all the practitioners and colleagues from the specialty to this meeting, and request Dr. Venkatagiri for a few opening remarks. Dr. Giri, please.
Good evening, President Dr. Nazar, Secretary Binil, our faculties, Dr. Kundra sir, Thondebhavi, and Dr. Jithin, coordinators Rajesh and Vijesh. We have faculty, very senior members, past President Agnihotri is there, Dr. Suresh, I see many VIPs there, S. Ramesh is there, Meenakshi is there, Anjali is there, and many have joined. I think more of the consultant seniors have joined this webinar than the junior. Dr. Shri is there, Anand Bangera. All I'm seeing are very eager to hear, but unfortunate that PGs do not know the importance of the senior speakers and this thing. That is an unfortunate thing. Hope that they will join soon. It was very difficult to get Dr. Kundra for the talk for the last 3 months. We are trying, but he was busy with the admissions and other things. We could get him for the talk. I know Dr. Kundra from the time he was quiz master in Calicut. I don't know whether you remember. I still remember how he conducted the quiz there, induction, maintenance, and other things, that resuscitation or something like that, the program with the MRR conducted in Calicut. And following that year, he was a faculty in ISACON at Kasaragod that year. From that time, we have seen Dr. Thondebhavi also similarly, more than anesthesia, he is talking on other subjects, non-anesthesia subjects also. Recently, he has published a book, Think Like an Anesthetist, and he has sent me a copy. I was going through that, not fully completed it. Everybody should read that, how he has made that book and went through that. And our people, I was many times telling that we should have topics other than anesthesia. Not only anesthesia, we should learn that other arts other than anesthesia. So hope that in one of the coming meetings, Thondebhavi will talk on non-anesthesia topic also. And Jithin, our own man, I need not tell much. He has shown his capacity in the last our ISACON and PG classes. brief this thing, I wish all the best for this webinar. I think we have only one webinar next week, and after that we have the national conference. I request you all in this meeting itself, come to Ahmedabad. It is now safe, and be there on 27th and 28th, attend the general body and the installation, and make the conference successful. Thank you, and wish you a good CME. Thank you.
Thank you, Dr. Giri. We'll go on to the academics. I request Dr. Rajesh and Dr. Vijesh to take over. Dr. Rajesh, please.
Thank you, sir. Today we are fortunate to have the Professor of Anesthesia and Critical Care and Academic Dean of JIPMER, Professor Pankaj Kundra, sir. He was introduced earlier by Dr. E.K. Abdul Nasser. And I think he doesn't need any introduction. Any student or academicians all over India know Pankaj Kundra, and very eager to hear from Pankaj Kundra. Any topic, he will present it in a very simple and presentable way. And I have been hearing Pankaj Kundra, and he's my teacher also from my MBB, my postgraduate days onwards. He has been a regular speaker in Kerala for all the state conferences, and he has come to Calicut also. And in spite of his very busy schedule as an academic dean, and he has consented to be a speaker here. We are very fortunate to hear from here. And the topic is Frailty and Anaesthesia. Nowadays, more and more of geriatric patients are coming to anesthesia requirement in our day-to-day practice, and the assessment, manifestations of frailty and strategies of perioperative management is very important to know, not only for the postgraduates, but for the practicing anesthesiologists also. We are very eager to hear from you. Over to you, sir.
Thank you very much at the outset, all the luminaries present out here. It's my honor. I'm really privileged to be on this platform. Thank you, Dr. Giri, for those kind words. Thank you, Dr. Nazar, for giving me this opportunity, Dr. Rajesh, Dr. Binil, and many others who are there, all the executive members. I'm going to share my screen now. So this is the topic which I'm going to talk about, frailty and anesthesia. Please forgive me if I'm a little underprepared, because it takes a lot of time to make slides, and I haven't had time to review through them, but I'll try to make the best of my efforts. Now, what is frailty? Frailty, to me as a layman, means increased vulnerability. But actually speaking, scientifically, frailty would be a syndrome where you find decreased physiological reserve and resistance to stress. Thereafter, there is an increased adverse outcome, and these stressors can be triggered by small physical insults. So the person can decompensate even with minor physical insults, and that is what is frailty, and we need to consider it more in depth. Looking at the worldwide incidence, 2006 to 2007, the age group above 75 years was about 1.5 million. 2014 to 15, it has gone up to 2.5 million, and we are growing. And very soon, some of us would be there in that age group. But if you look at 2014 and 15, the age group has advanced, and almost 1/3 of the population there is now above 85 years. What is the projection? 2050, it will be more than the Indian population when we'll have people more than 75 years. So that's the burden which we have now. And considering the kind of increase in the age group increasing age group, we need to consider it more seriously. What happens with frailty and age? When we consider an age group of 59 to 65, or from 75 to 79 and above 80 years, we find that frailty increases in age. And the overall weightage prevalence is about 11%, and it is almost to an order of 61,500 older adults which we are going to encounter. So this is the magnitude with which we are going to see the patients coming to us in near future. Now, when we talk about frailty, there are three components which have a complex interplay. Frailty and aging, they go together, and when we have to provide anesthesia to them, we have to consider these two factors in accordance to each other. So aging and frailty leads to geriatric syndromes. And when you provide anesthesia in these geriatric syndromes, the response of the patient to an anesthetic agent or the impact of anesthesia on recovery from surgery is great. And you need to have strategies to prevent adverse outcomes when you have patients who are aging and who are frail. What about geriatric syndrome? What do we mean by them? Geriatric syndrome is a complex area which involves many kind of symptoms and signs. The most commonest one which we encounter is delirium in 32%, incontinence in about 29%, and it is also accompanied by dementia. On the other two extremes, you have malnutrition and pressure ulcers, especially patients who are not too mobile. Finally, you have polypharmacy, which can lead to problems. There is mobility impairment, functional decline, and the problem which we see is falls which occur in these kind of patients and they present to the hospital. Now, geriatric syndrome, whenever the patients come with them, they increase the post-operative surgical complications, and especially in non-elective and major surgeries which are performed on them. What are the prediction tools? The normally used prediction tools of ASA physical status, revised Lee's cardiac index, and others do not take into account frailty and geriatric syndromes. So you need to have separate tools to screen the patients, especially in this age group. So there are two major conceptual models of frailty, which are frailty phenotype and frailty index. What is frailty phenotype? The frailty phenotype was described in 2001 by Fred, and they basically took about 5,000 patients above 65 years of age and considered these parameters and came out with a score. Basically, on the left hand side, you had the characteristics of frailty, and they could see what the cardiovascular health study measure would be with the characteristics of frailty. So they came out with a score, and if the patients had a phenotype of more than 3 criteria, they labeled the person being frail. What about the frailty index? Frailty index actually is much more interesting. It is an accumulation model, and in this accumulation model, they consider multidimensional risk states. There are many of them. And what do? Is they come out with an index by dividing the number of deficits present by the number of deficits measured. And when they come out with a scoring system, if the index is more than 0.3, then they term the person as frail. So these indices are available, the phenotype and the frailty index, and I believe these can be used when we screen the patients. So the frailty screening initiative was tried by Daniel Hall, and they concluded that once the frailty screening index was used, it was associated with decreased mortality. And that's the most interesting finding, because if you can find out which of your patients are frail, you can probably work on them for some time before we take them up for surgery. So the overall 30-day mortality rate, when they use the screening, decreased by almost half. That's very interesting indeed. And the magnitude of improvement at 180 and 365 days also improved considerably when they use the screening initiative. Can frailty be modified? So when we use these indices or screening indices, And if we find our patient is frail, how can we modify frailty, or how can we help the patient to cope up with the stress in a better way? So there are certain things which involve prehabilitation to improve the outcome. One thing is it requires a lot of motivation. It's very difficult to motivate the elderly. They are like children, but you cannot scold them. So to get their cooperation is a big task, and we really need to involve the family members and NGOs to help us doing in that. The first one is exercise and strengthening. If we can motivate them to do some sort of incentive spirometry, if not that, at least some amount of walking or some sort of exercise which can keep them out of bed. Normally, all the elderly above 75, they will be on many medications. And some of the medications are on paper, they may not be taking it. So you need to review the current medication status and the compliance. Cognitive screening also becomes an important part, and you will have to do a minimal a mental state examination to find out what is the pre-op cognitive function of the patient and where does the patient stand. All of them undergo treatment for depression or mood disorders. They may not be expressive. Some of them are alone. There is no one to take care of them. Most of it is psychological, because we have gone from a system of joint families to nuclear families. And moreover, the parents are left alone in a big house and the children are all away. So that's the biggest society problem which we need to address. And sometimes you need to intervene early to find out their family issues, go into the psychology a part of it. And I would say anesthetists are one of the good psychologists who can actually counsel these patients, bring some happiness in their life, and maybe help them to come over these kind of disorders. Improving nutrition. It is one of the most important factors. We may say that there is weight loss, patients may be weighing less, they may be eating less, but how to make sure that the proteins are incorporated into their diet in some way. Some of them are not able to chew well. They have loss of dentition, they have pain, they have difficulty in clearing their bowel, and therefore they cannot eat. The moment they eat, they get distension or they get frequent bowel habits or urinary habits. You really need to go into these factors. It's a very complex issue. And if you have one person, you will take almost half an hour to actually go into the kind of problems which they are facing. So yes, we need protein supplementation, but it's not about feeding unless they are able to clear their gut. They will not be able to take in much. And you can't force them to eat. So somewhere the protein supplementation has to be given, maybe some formula feeds which have formulas which are available. We can take their help and try to see if we can improve their nutrition. Physiotherapy and arranging social support should be one of our main jobs, because that is the only way that you will get some sort of support during the post-operative period when you really need them. They at least want to see their loved ones besides them. They want to see some relative around to take care of them. And what we have seen in COVID was an extreme, horrible condition which none of us want to see ever. Here, if you fall ill, there will be 5 family members taking care of you because you are having fever. But in COVID, the person who was ill was left all alone to deal with himself. And that is probably one area we will have to work more now, because many of them may be just left alone. And we need to really bring them into the mainstream to see that they are taken care of. Yes, the ERAS model here would play a major role in performing prehabilitation, but the protocol here has to be a little different. It is to be custom made for the elderly, and you have to find solutions, customized solution to each elderly who comes for an anesthetic procedure. And if we will be lucky if they are coming for elective procedure, but if they come for emergency, then the outcome may be not good. What about the pharmacological considerations? Because we will be using many drugs. So whenever we talk about drugs, there is one thing which we need to talk about. That is, what is the lean mass? What is the water, total body water? And if you look at the fat gain, which occurs by about 114% in 70-year-old versus the 25-year-old. So they lose a lot of protein, their muscle wasting is there, but on the contrary, they do gain as the fat content is concerned. The total body water loss is about 30% as compared to a 25-year-old. And the muscle loss is huge, that is 37% muscle loss. And that is where I'm concerned about the muscle wasting. Now, how will the drugs help us, and how do we take care of these drugs? All lipophilic drugs would require increased adipose tissue. And if you look at the total body water, which is decreased for the hydrophilic drugs, you'll find they have a reduced central compartment. But for lipophilic drugs, because the fat content has gone up, there will be larger volume of distribution. So with larger volume of distribution, you can expect longer duration of action. And with reduced volume of the central compartment, you can have higher peak plasma concentrations with the amount of drug which you normally give. The decline in renal function is not reflected by serum creatinine. That is what we need to remember. And for this, we need to actually estimate the glomerular filtration rate, which is called as EGFR. And that is remarkably reduced in the frail and the aged. So there is decreased renal excretion or elimination of the drugs, and patients have increased sensitivity to the drugs which we administer to them. Before they can be excreted by the kidneys, all these drugs need to be metabolized. They need to be metabolized to be made water soluble so that they can be excreted by the kidneys. For that, the metabolism of these drugs depends upon the hepatic blood flow, which is reduced. And there is also reduced activity of the cytochrome P450 system. So let's just look into this cytochrome P450 system in a little bit of detail, especially because the postgraduates may be there and it would be of interest to them. The cytochrome P450 system or the family has three components. It is CYP1, CYP2 and CYP3. When we talk about CYP1, it is subdivided into two categories. CYP2, you have various other categories, but CYP3 is of major concern to us, which forms the greatest component. And in that, especially the A4 by A5. The other ones are non-P450 enzymes, which are really not of matter to us. So out of all these cytochrome P450 system, which one do we really need? It is the CY2 family and CYP3 family, which is required. Rest of them we can do without. What about your CYP3 family, which is involved in oxidative metabolism, and it forms the majority of the enzyme system which deals with drug metabolism. So in oxidative metabolism, the drugs which are metabolized are local anesthetics like lidocaine, benzodiazepines and opioids like fentanyl. If you look at the CYP2E1, this is involved in metabolism of inhalational agents. But I think that can be ignored because inhalational agents generally come into the lungs, are excreted through the lungs by means of alveolar ventilation, and it's a very minute quantity of which they undergo metabolism. So I may emphasize here, that's the reason inhalational agents are much safer. You can titrate them, you can get them eliminated because they don't undergo metabolism. You put them through the lungs, they exert their effect onto the brain, and then they are eliminated by your alveolar ventilation out from the lungs. and we are finished with those inhalational agents. So that's the advantage of the inhalational agents whenever we use in such conditions. CYP2 and D6, these drugs undergo phase 1 reactions, and there is almost 1,000-fold difference in metabolism if there is an adverse drug reaction. So these are the enzymes which can produce adverse drug reactions, and especially when you consider most of the opioids like tramadol, pethidine, hydrocodones, oxycodone, and ondansetron. CYP2C9 is involved in metabolism of NSAIDs, phenytoin, and warfarin. Whereas CYP2C19, it is involved with the metabolism of proton pump inhibitors, phenytoin, diazepam barbiturates, and amitriptyline. All in all, if you ask me, I would just focus on 2 areas. One is the CYP3 family, where the oxidative metabolism is concerned. I would be concerned about CYP2D6 enzyme because this concerns with the phase 1 reactions. A lot of them would be getting tramadol and some of them would be getting ondansetron. CYP2C9 also, patients with osteoarthritis and other kind of painful syndromes can be having NSAIDs, phenytoins, and warfarin. So these are the main enzyme systems which we need to look at and see what it is. And believe me, there is a lot of genetic predisposition to these enzymes, how they handle the drugs. So it's very difficult to predict what could be the nucleotide formations in them, which will then how they will deal with the drugs. So these are the 2 areas which I would like you to focus, especially the phase 1 reactions, but the phase 2 reactions are really not affected, which is according to the blood flow or according to the hepatic blood flow. Coming to the cardiovascular system, a lot of these patients would be hypertensive. There is progressive stiffening of the myocardium and vasculature, and that's why they suffer from diastolic dysfunction. They can be predisposed to cardiac failure and major adverse cardiac events, and prevalence of cardiac failure is almost 75% in frail patients. They are cardiac autonomic dysfunction, their blood pressures are highly labile. With intubation, it will shoot up to 200. And soon it will be down to 70 or 80 millimeters of systolic. But hypotension, if it is prolonged and profound in response to anesthesia, is because the reactivity of the vessels is very poor. You give a vasoconstrictor, it may take 10 minutes for it to act. And when it acts, it becomes very difficult for that vessel to relax back. So that is why there will be a lot of upshoots and there will be a lot of labile blood pressures which you will encounter in these patients. And hypovolemia has an exaggerated effect. So some of them, just after induction, you will find that the BP has dropped. So it is wise that in the pre-op handling time, when we prepare, we make sure that their hydration is good. And none of them should receive bowel preparations. Because if someone has received bowel preparations, not only they lose a lot of electrolytes, but it really puts them down the hill. Now, this is an interesting article which was published in 2019 by Lancet Respiratory Medicine. I believe it is, to me, it's a game changer. Because what it tells us is about the post-anesthesia pulmonary complications, which are often seen with the use of muscle relaxants. So what do the authors say? They say that neuromuscular blocking agents are associated with increased incidence of post-operative pulmonary complications in patients who have undergone general anesthesia. So the culprit is the neuromuscular blocking agent. The problem with us is we use them very indiscriminately. The purpose of giving neuromuscular blocking agents is to provide muscle relaxation for a surgical procedure. And very often what we see is that they are being administered on half-hourly basis, 45 minutes interval, without even monitoring the neuromuscular, without even neuromuscular monitoring. That's a dangerous game to play. The conclusion was that the neuromuscular blocking agents and general anesthesia would cause increased postoperative pulmonary complications. What the authors also tell us that even a single dose of a neuromuscular blocking agent, when it paralyzes the diaphragm, then the kind of recovery of diaphragm which has to occur doesn't come out well, and they get predisposed to post-operative pulmonary complications. So if they have a post-operative pulmonary complication, the mortality rate is almost 40% in the elderly patients. The reason is because of aging, there is progressive loss of lung parenchyma elasticity. The functional alveolar surface area is reduced, and there is reduced respiratory muscle strength. And this we would have seen that they are not able to cough out their secretions. Many a times we have to resort to oral suction to stimulate them so that they can cough out secretions, but they do not have enough strength to cough their secretions out, and many of them would undergo even a small mini tracheostomy. So with all these things, they have an increased ventilation perfusion mismatch. There is inability to clear secretions because of reduced airway reflexes and weakness, and that accentuates existing hypoxemia and atelectasis. So please keep that in mind, and when these things happen, they are more prone to risk of aspiration. So this is the area I would probably feel that all of us should focus on. Believe me, succinylmethonium is one of the best agents. It is the only muscle relaxant which produces muscular contractions before it relaxes the muscles for a small period of time. And if you give non-depolarizer muscle relaxants indiscriminately, you are indirectly harming your patients. A combination of regional plus general anesthesia does a lot of good, because even if the patient starts breathing and their cardiovascular parameters are stable, it doesn't matter to us whether the patient is breathing or not. It doesn't warrant a neuromuscular blocking agents just to make sure they don't breathe. Let them breathe. Let them have a stable hemodynamics so that you know that the anesthetic depth is adequate. The only time when the respiratory rate will go up or this is something which we need to really consider. There are two aspects to it. One is post-operative cognitive dysfunction and the other is post-operative delirium. Both of them indicate that there is decreased cognitive reserve. But how do they differ? Post-operative cognitive dysfunction, there is decrease in multiple domains of cognition, but in post-operative delirium, it's an acute fluctuating cognition which the patient has. Which is more dangerous? It is the post-operative delirium. Because post-operative cognitive dysfunction or POCD is to an extent reversible, and only about 1% of it is irreversible. And it can be seen even after 3 months. People come with POCD, 10% of them even after 3 months. So they require neuropsychological testing. What about post-operative delirium? This happens in patients who suffer hypoxic or ischemic injury, or there is impaired acetylcholine synthesis. So it leads to central cholinergic deficit, and the 5-year mortality is almost more than 7-fold. So that is where the problems can occur, and we need to differentiate between the two. And there are delirium screening tools which will tell you whether your patient is having a post-operative delirium or not. You may ask me, which is the best method of anesthetizing the patient? This paper is important because it shows that regional anesthesia, when it was given for hip surgery, there was significantly more perioperative complications, and which tells us about controversies in anesthesia for non-cardiac surgery in older patients. They talk about local and regional anesthesias, the risks during and post-surgery because of frailty. So the anesthetic technique, whether it is GA or regional in surgical patients, the significant impact on outcome remains unclear. Regional anesthesia, whenever we use, we must make sure what kind of techniques are used for sedation. The more you use fentanyl, midazolam and propofol, the more we get into problems. Even one single episode of hypotension is sufficient to cause post-operative cognitive dysfunction. Yes, it depends how much time the hypotension lasted for, but even a single hypotension episode is not tolerated well by the frail. The most problematic area is urinary retention, which increases morbidity, and a lot of them would have to be catheterized, especially if they have been given spinals or epidurals. So it's not easy. You give a spinal and post-op, you need to catheterize them. They have BPH. Things are not going to get better. So consider those things whenever you have a choice of anesthetic which you want to give them. Adjuncts like opioids delay gut motility and they produce more of delirium. So standalone technique of central neuroaxial blockade may be a good choice rather than adding any adjuncts, because you do not know how those additives will behave. Whenever you want to give a spinal or a regional block, their ligaments are calcified, it's better to use a Taylor's approach, which is L5S1. In general anesthesia, we use many drugs. I would still prefer or account for inhalational agents, minimal neuromuscular blocking agents, and probably reduce my opioid requirement to the minimum. You may have difficult airway in them because of cervical spine immobility or decreased mobility, TM joint issues, and face contour. The depth of anesthesia, when you consider MAC, it decreases by 6% per decade, plus frailty which should be added to it. And you will require BIS monitoring whether you use intravenous agents or you use inhalational agents to know what is the dose required to produce adequate anesthetic depth. Now, what are the adverse outcomes with frailty? Which patients are likely to have adverse outcomes? Can we recognize them? The factors for frailty and risk factors. If there is chronic inflammation, if there is immune activation, sarcopenia, that is muscle wasting, and in the endocrine system, there are age-related changes because decreased sex hormones, increased cortisol and vitamin D deficiencies. And if they are predisposed to these risk factors like genetics, acute and chronic diseases, lifestyle stress responses, and environmental, and a combination of them, then you have adverse health outcomes. So it's very difficult to predict which patient is going to have an adverse health outcome because it's difficult to evaluate all of them. Frailty Index is a good choice. We can use it and make sure we do perform prehabilitation in patients whom we think have been classified as frail or even pre-frail. Because there is increased mortality, worsened functional status, increased falls, increased hospitalization and long-term care. Now, this is a graph which gives an insight of how a frail patient is going to behave post-operatively. If the person is independent, relatively independent at B, And if he has the first insult, so before insult, he's quite independent. After the first insult, yes, he would be dependent for some time and he's coping up with it, trying to cross over to being independent. But before he reaches that state, there is a second insult. Then there is poor outcome. It is very likely that this person who is aged and frail would continue to be living on a dependent state. On the contrary, on the other spectrum, if the person has good functional abilities and if he has single insult, he would never be dependent and would just come out. The other one can be on the borderline. If they have a single insult, they would come down, but slowly they would pick up to become independent, but their functional ability may remain compromised, may not achieve the same as it was pre-op. So only these patients here are good ones who can tolerate the first insult and can become normal as before. The rest of them probably would have a problem. So in the end, my take-home message is they are fragile. Please handle them with care. Thank you very much.
Thank you, sir, for the excellent presentation. I'm sure that there will be a lot of questions or queries from the senior faculties, and I request the senior faculties to unmute themselves and ask questions or clarify their doubts. Unfortunately, there is less number of postgraduates here. There is a lot of senior faculties.
Sir,
there is comments from Dr. Manjunath, Dr. Meenakshi Sundaram, Professor Meenakshi Sundaram.
Thank you, sir. Thank you, Dr. Rajesh. It's a wonderful lecture. Just I want to interact with the sir. Whenever sir is delivering a lecture, I will be always there. Just for interaction, I want to know, sir has mentioned about neuromuscular blockers produce post-operative pulmonary complications. So the question is straight. In DU ulcer perforations in a 70-year-old man in a state of shock, compulsory we have to give GA. That is my point. So what is your anesthetic technique? That is the first question. Second, you said pulmonary complications are due to neuromuscular blockers. I want to know whether the paper quotes it is due to neuromuscular
such another affiliation number
or due to IPPV during anesthesia.
Thank you, Dr. Meenakshi Sundaram. It's a pleasure to interact with you. Yes, DU perforations pose a problem. And if the patient's condition is stable, if they are not requiring preoperative resuscitation more than resuscitation with IV fluids, and we take them up for surgery and the DU perforation is preferably not more than 24 hours or less than say 36 hours, then these patients are good. But my suggestion would be that whenever you give relaxants to such patients, please undertake neuromuscular monitoring. Do not give drugs without knowing how they are going to interact with the patient and when the top-up dose should be given. So that's the only point I wanted to drive home, that use your discretion power by helping to use the neuromuscular monitoring to guide you with the amount of dose of neuromuscular blockers which you want to administer. Don't give them at half-hourly intervals, because these frail and ageds handle these drugs very differently. So that's one piece of advice. The other part is, we have published a study in ERAS model in patients undergoing DU perforation. I think that was the first study all over the world which came from JIPMER, where we used epidural in combination with general anesthesia in patients who were resuscitated only with fluids, who did not require vasopressors and others and were relatively fit to take up. But yes, it was not in the elderly and frail. So I cannot extrapolate that finding to the frail and the elderly. But otherwise in DU perforation, even if you go ahead with an epidural plus general anesthesia, you will require much lesser amount of neuromuscular blockade, which you normally do in surgeries. The second aspect of the question, sir, can you repeat, please, sir?
Yeah, sir, the question is, you have mentioned post-operative pulmonary complications are due to neuromuscular blockers.
Yes.
Now I want a detail in that. In fact, it is a clarification whether
So
post-op pulmonary complication is directly due to the drug or it is due to the IPPV which we are administering during anesthesia.
Yeah, I got it. No, it is not due to IPPV. It is basically because of drug. How many of us, before we extubate, do follow a subjective or an objective criteria of recovery of neuromuscular blockade? None of us do that. And if you look at neostigmine, if the patient is recovering well and the recovery is almost to 80%, if you give neostigmine to them, then the airway reflexes get reduced. It adversely affects the patients. So the practice which we normally do is without any monitoring. So my single advice would be that whenever you use them, please try to, in elderly and frail, use a neuromuscular monitor to guide you with this. IPPV does not affect adversely the outcome. It is basically the metabolism. Basically, we do not look at the recovery. That is what is creating more of an issue.
Thank you, sir.
Yeah, good evening, Dr. Pankaj. I'm Dr. Manjunath here. Thank you very much for an excellent presentation as usual. And I thank ISA Kerala branch for organizing this. Yeah, my question is exactly almost on the same line as Dr. Meenakshi Sundaram. Basically, what I was telling is many of the time, these people are likely to have more complications in upper abdominal surgeries. And they are often acidotic sometimes when we have to really paralyze them and take them for a longer duration of surgery. And they'll be breathing faster also. I agree with you about the epidural part of it. But otherwise, I would just like to make one point here is that is when you not only you need to monitor very clearly, like something like double burst stimulus or something like that, or TYF ratio, also you should, I would think, select the muscle relaxant appropriately, and probably if you have, you can use something like Sugammadex to reverse it and continue to monitor for some time in the post-op. That I'm just want to know your view on this.
Thank you, Dr. Manjunath. It's pleasant to see you again. Yes, your queries are correct and your suggestions are absolutely right. Sugammadex, not many of us have a hand over it, and I've personally never used it. Yes, the choice of muscle relaxants do make a difference. I totally agree with you. But it's like using lente insulin and regular insulin. You may use any one of them, whatever dose you want, but you will always monitor your blood sugar, isn't it? You titrate all these drugs to a target blood sugar value. I put the corollary same to the neuromuscular blocking agents. Monitor it, then give the doses, you will be in a safe zone. That's all I need to say. And yes, in the post-op recovery, once you have satisfied the objective criteria of recovery and giving a neuromuscular reversal agent, then it is perfectly fine. There should not be an issue. You may do the, you can do that TOF again in the post-operative period, but giving a TOF at that particular time, it is good. The elderly will tolerate that because it does give you the supramaximal stimulus of about 60 milliamperes does produce a little bit of pain, but they would tolerate that. But I guess if you use a DBS or a double burst stimulus, even in the post-op, to make double sure that the recovery is appropriate, that's a good option. I would consider that.
Thank you, Dr. Manjunath. Thank you, sir, for the comments. And I also invite Dr. Gurudat, Dr. Shamshad Begum, and Dr. Ramesh for their comments.
Hello,
Sir.
Sir. As usual, sir, excellent lecture, and learned a lot about frailty, and because we had known more about geriatrics, not much about frailty. So one thing I would like to comment here that it's always better to avoid majority of the surgeries in these frail patients. If we can manage these patients conservatively without kind of any surgeries, I think they do much better than subjecting them for surgery as far as possible. Like I can give many instances wherein my own mother-in-law, who is quite frail, and she is having interstitial lung disease, almost 24 hours on oxygen. She had a olecranon fracture. So many of the orthopedic surgeons suggested that she has to undergo surgery immediately. So one of the orthopedic surgeons said, "Oh no, we'll go for conservative management." So we went for conservative management. Now it's more than 2 years. Her complete movements are there. She's almost normal now, as far as the upper limb is concerned. So that is one thing I would like to comment on. So the other thing is, as Dr. Kundra was suggesting about the non-depolarizing muscle relaxant, yes, definitely they can produce quite a bit of change as far as the morbidity and mortality is concerned in these patients, especially the post-operative pulmonary complications. So what in the initial days of my practice, so of course, it's almost about 30 years back. So during those days, we had only long-acting non-depolarizing muscle relaxant like, pancuronium was the routine drug that was used. So during those days, what we used to do is we used to leave these patients, even when they come for acute abdominal emergencies, especially the old patients, geriatric patients, on spontaneous ventilation with ether. Of course, ether was routinely used, and that ether has got very good positive things regarding cardiovascular system. It maintains the blood pressure, it maintains the heart rate, and leave them on spontaneous ventilation with these drugs after intubating them with succinylcholine. And once the abdomen is opened, the surgeon usually do not require much relaxation. Again, for closure of the abdomen, again you give one more dose of succinylcholine, ventilate, and then that the patients would be out of succinylcholine very rapidly. So these are some of the comments I just want to make. So anything regarding these, Dr. Kundra?
Sir, thank you very much for making those comments. I'm really delighted that I particularly mentioned that paper because I wanted a debate on it. And I'm happy that there is a lot of focus on neuromuscular blocking agents. Thank you very much for debating on this aspect, because we really need to look into it and new ideas will come. Yeah, regarding surgery and conservative management. Sir, there are two aspects which we need to consider. Suppose the same patient who was independent, who was mobile, has a hip fracture. Then the whole course would be down the hill if they are not operated and mobilized immediately. So it all depends upon the patient. I perfectly agree that it need not be operated. It is perfectly fine. So it depends upon the preoperative condition of the person, how well they are, how good they are, they want to be mobile. That's why knee replacements are occurring in the adults, because they need to mobilize themselves, they need to live a normal life rather than be confined to a bed. But if the existing comorbidities are so high, then again you need to consider what is going to happen if you subject a person for surgery. But in case you perform an early surgery and you are able to mobilize them out of the bed early, then the outcome may be good. But it all depends upon the motivation of the family, of the patient himself. That makes a lot of difference before we make a choice on conservative or operative management. I would consider the pre-op condition and the type of surgery for which the patient has to be subjected to. Secondly, which you pointed out, you pointed out a case of ether and all. I totally agree with you. We used to do the same, because I've used ethyl chloride, I've used open ether, all those things we have used earlier. And we used to give small amount of scoline before, when they wanted to close the peritoneum. I agree we have better agents now. I also agree that we have better monitoring systems in place. The problem which we need to address here is when you lose the diaphragm's tone, that is where the problem occurs. As soon as the diaphragmatic tone is lost because of a neuromuscular blocking agent, it gets pushed up into the thorax. And then you see basal atelectasis happening. Not even before you administer a non-depolarizing muscle relaxant. The CT scan images show that immediately after induction, as soon as the diaphragmatic tone is lost, there is atelectasis which happens in the basal regions, and that is accentuated as soon as you give a muscle relaxant. So the problem is now when you have basal atelectasis which has already happened, how much can you recruit the lungs? Recruiting lungs in elderly frail is dangerous, which Dr. Meenakshi Sundaram was telling us about IPPV. IPPV is okay when you monitor your airway pressures, you monitor the kind of ventilatory mode which you give them, and the amount of sustainable PEEP which you give them. But if you try to recruit these areas which have got collapsed because of relaxants, then you may produce a lot of volute or barotrauma, and where the elasticity can be lost. So that's the concern. Scoline is one agent which I still emphasize is never going to leave us because it's a remarkable drug. Even in difficult airway, it is the one which opens up the airway because it induces muscle contractions. And if you look at the videos I have presented in conferences, the airway space opens up. So you can actually ventilate the patient. But with non-depolarizer agents, the airway place gradually contracts and closes down, which doesn't happen with the scoline. Scoline will just increase the airspace like this because of fasciculations. So those are good things which are there. We need to consider it. It's not a drug which is going out, but I'm happy that we are discussing about neuromuscular blocking agents today. It's a healthy debate. Thank you, sir.
So one more thing I just want to suggest, sir, is nowadays we have various spontaneously breathing modes of ventilation with anesthesia machines also, or workstations. Like pressure support is there in many other workstations. So why can't we leave these patients on spontaneously breathing with amount of pressure support? So
absolutely,
so
sir.
that we can
totally
avoid muscle relaxants, as you said.
Yes, agree. Totally agree.
And, yeah. Another thing is, just before extubation, so many of the students, because this actual lecture is mainly for the students also, that they would give 100% oxygen for these patients. So that I think should be avoided, so that we can give about 0.5 or 0.6 FiO2 at the end of surgery. We combine with the air, so that the post-operative atelectasis also can be reduced and post-operative pulmonary complications can further be reduced. So one more thing I just want to ask you, that in these patients, can we go for, if possible, supraglottic airway devices instead of endotracheal intubation, so that the requirement of whatever the muscle relaxation or anything would come down drastically, and we need not have to extubate them immediately after the surgery. We can allow them to come out by themselves, and they can pull out the supraglottic airway device once they are completely come out of the muscle relaxation. So what about these two comparisons?
I agree with you, sir. It's perfectly fine the kind of airway device you use. If intubation is indicated in abdominal surgeries, you would definitely want to have the tube and secure the airway. But in surgeries where you can avoid intubation, you can always use supraglottic devices, at least the second generation ones. That is perfectly fine. That I leave it to the anesthetist, and all of us will do the same. So that's not an issue. Yes, spontaneous modes can be encouraged. That's a good choice. Definitely. Points well taken, sir.
Dr. Rajesh,
Yes,
request to ISA Kerala, you can arrange a lecture by Dr. Gurudat, how not to be frail in spite of increasing age.
No, that is one thing we have to prevent. Dr. Meenakshi Sundaram, sir, we have to prevent frailty. That is there. We have to be fit throughout. So prevention is best.
As advances, we have to prevent cognitive dysfunction also.
Yeah,
Kundra sir has mentioned about post-operative cognitive dysfunction. There are a lot of drugs now, sir. Cholinesterase inhibitors, anything which we can use preoperatively to prevent the occurrence of post-operative cognitive dysfunction. So there are a lot of clinical trials going on now. Done as a pill and all.
Yes, sir, I agree. I agree they are there, but I think it's better to use the frailty index, look at their pre-op cognitive functions before you use them, because none of the drugs are absolutely safe. They have their own issues. So if you can look at their do an MMSE and see how the cognitive function is, then you would be able to probably know which one of them are likely to go into to have a cognitive dysfunction or not.
And nowadays, most of the balance regional anesthesia is part of most of the balanced anesthesia techniques. Lot
Yes.
of truncal blocks has come.
Yes.
So, so what's your comments on that? Does it help in preventing cognitive frail patients?
No, sir, I do not agree with that, that regional blocks alone would prevent that. Because as I said, those field blocks are good enough, they can prevent your somatic pain. The visceral pain component still remains to an extent. And then if you have to supplement your anesthesia along with your blocks, that's a better choice rather than only relying on the areas where you know there will be some issues. But if you can manage only with your local anesthetics, that is a perfect, that would be a perfect blend without giving any sedatives, without giving any other drugs, then those local blocks are extremely useful.
I mean, general anesthesia in combination with the
yes, sir. Yes, sir. Both can be done. And if you want to give a brachial plexus block for something like upper arm or a forearm surgery, that is perfectly fine. That is perfectly the best way out. So if you can give isolated nerve blocks to perform a particular part of surgery, for limb surgery, it is fine. Abdominal surgeries, you will have to combine them with your anesthesia. A combination of both is to be used. So that is the way to move forward.
Thank you, sir. Dr. Shamshad Begum, any comments?
Yes, thank you, sir, for the excellent presentation as well as the discussions that has going on now, and also the initiative that you have given to us. And also, I want to just, Rajesh has already described that, sir, how we can, because most of the patients that we are getting nowadays is in the old age is for the orthopedic surgeries. So most of the time we prefer to give regional blocks. So how can we assess the frailty index in all these patients, sir? Is there any specific method or something like that? Because we cannot assess how much of which of the patients are going in for the problem in the especially in the post-operative period. In the intraoperative period, we will be able to manage very nicely with our nerve blocks and all. But in the post-operative period, most of the patients, some of the patients may go in for these blocks and all. So
I agree with you, madam. Thank you for your comments. The frailty index exists. And if you can look at the frailty index, you can actually point out what the index is. If it is more than equal or more than 0.3, then these individuals are termed as frail. So if they are termed as frail, then you have to be extra cautious with them. And these are the patients in post-operative period would require extra care, as well as during anesthesia, the type of techniques and drugs which you use.
Okay, sir. Okay. Thank you, sir. Thank you very much.
Thank you, ma'am.
Sir, is there any Indian guidelines for that handling of the geriatric patients?
Let us take an initiative and form the Indian guidelines.
Okay.
There are none as present. But also remember, Dr. Rajesh, guidelines are not tram lines. They are the ones which are formulated. I know they are becoming the root of the medical system now, but guidelines are for people who do not know about certain things, just to give them a guidance how to do how to handle those cases. So you have a lot of leverage to come out and do what you feel customized to your patient. But if you become too inclined towards guidelines, then you may not do harm, but at the same time, you may not be good to your patient. That is how I look at it. It's good to have guidelines. That's perfectly fine. But if you ask me, I would probably interact in this manner and see that doctors customize their techniques to the patient's requirement. You go to a tailor, you give all measurements, and then you get a proper thing stitched. And that is how our anesthetic techniques should be. They should consider the pre-op status, the other factors which are modifiable, and then treat our patients accordingly, rather than the list which has been provided to you.
Thank you, sir. Dr. Ramesh.
Yeah, I just put in a t-shirt right now. It's okay. No, I think it's a good discussion, but I don't want to take a lot of time. It's already an hour of your thing. Only thing I have heard about walking encyclopedia, but I think Pankaj Kundra is speaking in encyclopedia. So I think I can't understand about half of them and where it is going. It is really, and second, I think there's a difference I found. I thought geriatric is different and fragility. It looks like both are a little bit of a different type of problems. So I'm really lucky that I don't come into any of those levels. So I stopped anesthetic at 18. So I think neonate and fragility is more or less the pharmacology and pathology looks more or less similar when he is presenting, but I think we should be careful in the fragile as well as the preterm patients. I think that's how I take your lecture, but it's a lot of things to be learned. I think we have to go again. And thank you, Dr. Kundra.
Sir, thank you, sir.
Thank you, sir. So any postgraduates for any questions or queries? It's a golden opportunity to clarify directly with the Kundra sir. I don't think there is any more queries. Thank you, sir, once again for the excellent presentation.
Thank you.
And we are fortunate to have you here again. Thank you, sir.
My pleasure, and I'm really honored to be here. Thank you very much. And thank you for that healthy discussion. It meant a lot to me.
Thank you, sir. Now we will go to presentation by Muralidhar, Dr. Muralidhar Thondebhavi, a talk on recent advances in regional anesthesia. He is a senior consultant anesthesiologist and pain management specialist in Apollo Hospital, Bangalore. And he has got 3 gold medals to his credit during his MBBS days, and he has got 11 international publications. And recently I come to know that he's an author too, and he has published a book known as Think Like an Anesthetist. Hope it should be there in for all of us. Think Like an Anesthetist. And his other interest other than anesthesia is photography. Over to Dr. Muralidhar Thondebhavi.
Good evening, ladies and gentlemen. I would like to thank the Kerala chapter of ISA for giving me an opportunity to speak about recent advances in regional anesthesia. In the next 20 to 30 minutes, I'll be speaking about what's new in our field of regional anesthesia and where are we heading. So to start my talk, I don't have any financial interests. It all started in 1846, as we all know. General anesthesia was something extremely new and gave birth to the field of surgery. Regional anesthesia started, as we all know, with cocaine, and later, as we can see in this graph, it increased in popularity till around 1970s when there was a small dip. Now, this dip can be attributed to probably discovery and introduction of newer inhalational agents, and also a little bit of decrease in popularity of regional anesthesia because it was still considered an art that only few could practice. But as we all know, things have taken a big upswing since the start of the century. And I'm sure all of you would agree with me that ultrasound is the largest change that the field of regional anesthesia has seen. Imagine that you were in a black room, no lights, not knowing where things are. When we started doing regional anesthesia, we were given the anatomical landmark saying, go 5 steps forward, 3 steps to the left, and there is your treasure, the nerve, and put some local anesthetic. But with the introduction of ultrasound, we have thrown light into this room. And now we can see the structures which we can damage or the structures which can damage us. So this has been the big revolution that we have seen in the last 2 decades. Now, what I'm going to do in the next 20-30 minutes is talk about advances in technology and the equipment. What is the advances in our understanding of the anatomy around the nerve, the safety issues, what are the newer blocks? I'm not going to talk about all the new blocks, but only a few relevant blocks, and anything new in pharmacology, and where are we going when it comes to outcomes. Now, coming to technology. Now, as we can see here, the ultrasound transducer has got 2 properties. One is the frequency, which in turn determines the penetration and the resolution. Now, as you can see, as we increase the transducer frequency, we increase the resolution, but we sacrifice the penetration of the beam. And this has been a catch-22 situation when it comes to using probes, because the ones with good resolution cannot see deeper. Now, this is an example of what we normally see with our equipment nowadays. We can't see much of the radial nerve in the radial groove here. You can just see the local anesthetic as a hypoechoic spread. And even the structure of the muscle is not that very well visible. So what are we doing, or where is the research happening in regards to improving this? Now, when it comes to needle tracking and visualization, the first thing I would like to talk about is this new technology that is being tested. We will be seeing clinical trials soon because right now it's being used in animal models. Now, it's called a smart needle because this needle has got an optic fiber, and the machine here reads the resistance or the pressure to injection. Now, why this is helpful is it prevents intraneural injection of a local anesthetic. Now, it works with regards to this principle here, physics principle called the Fabry-Pellot optical cavity, wherein the light is bounced off 2 membranes, and depending on the pressure it encounters, the device calculates a real-time acquisition of the pressure. The second thing in the pipeline, which can help our visualization, is something called as a Piezo Tracker. Now, the Piezo Tracker is nothing but a small piezo crystal which is attached to the end of the needle. And as the needle is advanced, a green circle gets highlighted on the screen. Now, the green circle is the tip of the needle. So even if we are not seeing the needle very well, we know where the tip is just by the green circle. There have been studies done, clinical studies with this technology, especially for lumbar plexus block. Like the deeper blocks is where we'll appreciate this. Coming to something again very exciting is something called as micro ultrasound. Now, we all know that the traditional ultrasound is up to around 15 megahertz. So the higher frequency probes go sometimes up to even 15, 20 megahertz. Then we have the high frequency ultrasound, which is used in specific applications like musculoskeletal radiology, which can go up to 30 megahertz. But what we are looking at in the future probably is something called as micro ultrasound, wherein the probe is actually along with the needle, or it's like a needle-like probe, which is sent deeper close to the nerve. And this works at a frequency of 30 to 75 megahertz, and its resolution is it can pick up structures as small as 40 to 100 microns. Now, this is the picture of how it would look in a micro ultrasound. So you can see the nerve very clearly delineated, and you can see the fascicles so clearly, the interfascicular space, and you can see where the needle is. So we might be looking at this technology coming in, I don't know, in the next few years or a decade or so. The other thing which is being trialed is something called as elastography. Now, this is an example of how poor can an image be in our traditional ultrasound. The fascia iliaca is something which we have to kind of, assume that it is there because we see so many hyperechoic lines. And then once the local anesthetic spreads, we think, yes, this might be the femoral nerve. But when this technology is applied, we see that the color changes based on the elasticity of the structure. So we can see the yellow here is probably the femoral nerve, the anterior and the posterior divisions. And we can also see a faint line, which is a needle, which is close to the nerve. The other thing which all of us are pretty excited in most of the walks of life is the use of artificial intelligence. Now, artificial intelligence, especially when it comes to image analysis, has been used in traditional radiology, not in ultrasound, but in CT scan and X-rays. And with ultrasound, what we have used, this is just a paper which they had used about for sciatic nerve, is they take images, acquire the data of sciatic nerve in the posterior thigh, and then whenever a new image is fed into this artificial intelligence algorithm, it uses the previous images to use an algorithm and then come out with an answer that where the sciatic nerve could be. So this is something which is still in the pipeline, and we might see some exciting trends coming out in this regard. Next is training. Now, training is something, it's a steep learning curve, especially when it comes to ultrasound, if somebody is not used to ultrasound. And this technology here, you can see, is the eye movements can be tracked of the trainee. And the trainee can be taught to see the right structures, therefore improving the training. So this is just a graph of how the blue line shows how the eye gaze kept moving and kept searching for the structure. And it can be helpful even probably in examinations in the future. So this is where we are with regards to technology and the newer advances with that. Now coming to anatomy. Now we all know that a nerve has got nerve fibers which are bundled together in fascicles. They are covered with one layer of connective tissue. Then that is covered again with another layer of connective tissue, and they're bundled together as nerves. Now, what we know about this is the individual axon is covered with something called as an endoneurium. The group of axons with an endoneurium covering are covered with perineurium. Then we have epineurium, which sometimes is called the interfascicular connective tissue. That's the inner epineurium, and people call the outer layer as the epineurium. And outside epineurium is something which we have discovered in the recent years is something called as a paraneural sheath, which I'll talk in the next few slides. Now, the possible sites of injection, as we know right now, is the paraneural, the subparaneural, the subepineurial, and intrafascicular. Now, the advantages of the subepineurial and intrafascicular are not that high compared to the risks, because the resolution with our ultrasound right now is we can't see the needle inside the epineurium that well. So not knowing where the needle tip is, it is safe now to consider that paraneural and subparaneural injection sites are the best when it comes to a nerve fiber. So this again shows how we can be deceived when we see a supraclavicular brachial plexus on the ultrasound. We don't see the trunks that well. Now, as you can see in the histological picture here, the superior trunk is divided into an anterior and posterior division. Then you have the middle and the inferior trunk. Now, we cannot see that well with ultrasound. So there is a possibility that even if we are seeing the needle tip, the best person doing ultrasound, there is a possibility that the needle can be intrafascicular, intraneural, therefore damaging the nerve structure. Now, why is this important is, if the neural tissue is more, as we see in this graph, the interscalene has roughly 50% of neural tissue, but as we go down subcoracoid, it drops to around less than 30%. So the more the neural tissue, the more the chances of damage. The same thing is actually shown in this, wherein the sciatic has got more neural tissue proximally at the mid-gluteal level, and the neuropathy rate is double when compared to the popliteal level. And the same thing with interscalene, where the neuropathy rate is close to twice compared to infraclavicular rate. So we need to know where the structures are, because if we go into the fascicle and inject intrafascicular, there is a chance of damage. This again is an intraneural where we have breached the epineurium. And the safer injection is perineural, or as we are realizing now, the sheath which covers, which is the paraneural sheath. And there have been devices which have been kind of created to improve safety. And the main thing here is we are looking at the pressure when injecting. If the pressure is more than 20-25 psi, then we can say that probably the needle is inside the fascicle, therefore damaging the nerve. And outside the epineurium, the pressures generally are less than 15 psi. Now, the paraneural sheath is something which we have been kind of looking at from the past 10 years or so. And it is a layer, a connective tissue layer just outside the epineurium. So the external epineurium, then comes the subparaneural compartment, and then the paraneurium. Now, the outside paraneurium is the epimysium and subepimysial perineural compartment. So there is a subepimysial perineural compartment and a paraneural sheath. Now, this was one of the first images way back in 2013 by Dr. Karmakar and his team, looking at high definition ultrasound, where they detected this paraneural sheath. You can see the paraneural sheath highlighted by the white arrowheads here. And they also showed that once the injection is in the paraneural sheath, there is an excellent circumferential spread of local anesthetic around the nerves, which gives a better block with regards to onset and also efficacy. Now, recently, Dr. Karmakar and his team have published this year in Regional Anesthesia and Pain Medicine about the paraneural sheath and facial compartments in the infraclavicular area, the costoclavicular space and infraclavicular area. So again, they have shown that there is a clear paraneural sheath which exists in this area, and our local anesthetic, if injected inside this compartment, gives a better outcome. Now, this again shows the various layers. So as we can see here, number 1 is the fascicle, 2 is the perineurium, then we have 3, which is the interfascicular connective tissue, the same here, 4. Then the 6 is the epineurium, and then later we get 9, which is the paraneural sheath. Now, coming to safety. Now, what are the new things that are there in safety? Now, as I mentioned in the slide a few slides ago, we have some devices which can detect the inline pressure, and if more than 15 to 20 psi, we shouldn't be injecting to prevent intraneural injections. We have devices which prevent us from injecting after certain pressure, in this case 15 psi, and therefore automatically it limits the injection and therefore prevents nerve injury. Then we have something new where the anesthetist completely controls without giving the injection, the variable of the injection to an assistant, and therefore controls the safety. So this is called Safira, wherein this yellow and green pedal is basically a foot pedal through which the pump is activated, and the pump contains a syringe which has a local anesthetic attached to the block needle. So when the anesthetist uses this, this actually prevents injections more than 15-20 psi. The other thing which is there for improving safety is another type of fitting called the NR fit, which is patented by a company Braun. And again, this is to prevent inadvertent connection of local anesthetic to an IV line or vice versa. So taking some other drug, say something like tranexamic acid, and injecting it into a intrathecal space will be prevented if you use such connecting systems. Now, coming to local anesthetic systemic toxicity, where are we in 2021? Now, this paper actually highlighted an excellent picture here, which tells which blocks are prone for local anesthetic toxicity. So when we're using ultrasound, you can see that lower limb and subcutaneous infiltration in patients with no comorbidity, even in pregnancy, is pretty safe. But as we go from no comorbidities to a patient with a frail patient with cardiac disease, the risk of local anesthetic systemic toxicity increases. And the same goes if we go towards intrapleural, intercostal, paravertebral, or even a facial plane block. And most of the recent case reports of local anesthetic systemic toxicity have been with facial plane blocks. So be a bit watchful when you're doing a tap block or any other facial plane block. They're not a simple block where there's no complication. The local anesthetic systemic toxicity has been seen in such blocks. And this same table becomes more red as we go towards a non-ultrasound and higher doses of local anesthetics. The main thing in this paper they highlighted was that education should be given to everyone who uses local anesthetics. So it could be a dentist, it could be a surgeon doing infiltration, or a plastic surgeon doing tumescent anesthesia, or even paramedics. They saw that the last incidence has decreased in the operation theater, but has increased outside the operation theater. So this is where our future lies as anesthetists, that we should be actively training people who use local anesthetics. Now, coming to pharmacology, we know we were very excited. We were wondering when this will come to India. This is liposomal bupivacaine. And it has been more than 10 years now since the introduction of liposomal bupivacaine in the US. And sadly, I would say that it has not made a big dent with regards to regional anesthesia. This review article in 2016 said liposomal bupivacaine infiltration has questionable clinical advantage. And something much more recent, which looked at total knee replacement, they studied 88,000 people who underwent total knee replacement, of which 18,000 were given liposomal bupivacaine. And they said liposomal bupivacaine use was not associated with decreased odds for opioid-related complication. So it didn't make much of a difference when it came to the outcomes. So I don't think we should be pretty excited about this unless something radical comes up with this nanotechnology kind of drug delivery systems. The other thing which is very important, and that's the reason liposomal bupivacaine came up, was how do we extend the duration of the block? Now, we don't want the blocks to kind of wear off and patients have severe pain in 5 hours, 4 hours, or even 10 hours. So the things which we have used are adjuncts, which probably have increased anything ranging from 6 to 8 here, but in my personal experience, up to 24 hours. Then, of course, as we saw, the liposomal bupivacaine hasn't made much of a dent. And we do use a lot of continuous catheter techniques in our daily practice. Now, adjuncts which have been studied with some amount of literature strength are things like epinephrine, dexamethasone, which can affect the vascular contractility, dexamethasone, which works on the glucocorticoid receptors. Then we have clonidine and dexmedetomidine, which work on the alpha-2 receptors, and buprenorphine and magnesia. Now, where do we stand with regards to this? Now, we know that with regards to the safety profile, there are only three which are safe. One is adrenaline, one is dexmedetomidine, the other one is dexamethasone. There's not much of safety data of usage of adjuncts in peripheral nerve blocks for clonidine or buprenorphine. But out of these two, the dexmedetomidine and dexamethasone, the recommendations presently are to use dexamethasone as a systemic adjunct, because many of the studies which have shown not much of a difference with usage with the local anesthetic or systemically given. So therefore, the recommendation is to use dexamethasone as a systemic dexamethasone at the range of 0.1 to 0.2 milligram per kg body weight for patients undergoing surgery with significant post-op pain. Now, coming to blocks, as I told you earlier, we'll be covering only a few relevant blocks, and we'll start off with the upper limb. Now, one thing which has been a change of practice in most of our clinical practices is the upper trunk block. So nowadays, I don't tend to do an interscalene as a traditional for shoulder cases. We tend to go for upper trunk block. The reason being, there is an element of phrenic nerve sparing which can occur with this, especially with lower volumes. So upper trunk is when the C5, C6 form and divide into three branches, as we can see here, 1, 2, 3, which is the anterior, posterior, and the suprascapular nerve. So you can see the suprascapular nerve taking off in this cadaveric specimen here. And as you can see, the phrenic nerve is actually going over the anterior scalene quite high. And therefore, when we use a low volume, we tend to kind of avoid the spread of local anesthetic to the phrenic. And it has been shown that the upper trunk block does have a phrenic nerve sparing effect. Now, this is how the superior trunk looks. And this is a suprascapular nerve, which is taking off and the needle coming in here. Now, this is a video which shows the superior trunk, and this is a needle. So we can see the superior trunk here, 3 branches, and you can see the local anesthetic, which will be injected shortly. And this has shown to decrease the phrenic nerve involvement when it comes to shoulder surgeries. Next, up in the block, which is new, is the costoclavicular block. Now, the costoclavicular block has become popular after description by Manoj Karmakar and his team. And this is done where the cords are neatly arranged next to the axillary artery in 2 compartments. So the lateral cord lies in one compartment and the posterior and the medial cord lie in another compartment. Now, how do you do this block? Now, the costoclavicular space is the space between the first rib and the clavicle. That's why it's called the costoclavicular space. And the probe is placed along the long axis of the clavicle, and the needle comes in from lateral to medial. Now, this is how it would look. So the axillary artery here, the lateral, the posterior, and the medial cord. And when the block is being performed, this is from the other side. This is another patient. So you can see the needle coming in here. This is an echogenic needle which we are using, because you can see the end of the needle very well. And you can see the local anesthetic spreading around the cords. So this is the costoclavicular block, which is a good alternative to infraclavicular block or even axillary block. The other block, which has seen multiple publications coming out in the last 4 or 5 years, is erectrospinal block. Now, the erectrospinal is given as a paraspinal injection at the level of the thoracic spine, which was initially described at thoracic spine, but people are using it at even the lumbar level, where we can see the transverse process of the spine. The erector spina is the first muscle, then we get the rhomboids and then the trapezius. So the local anesthetic is injected just above the transverse process. It's a safe block because we are not going anywhere into the paravertebral space in between the transverse process, and there are not many structures that can be damaged here. And the other good advantage with the erector spina is even catheters can be used and left in place for longer duration. There are multiple, more than 200 to 300 papers now in literature with regards to erector spina. And this narrative review looked at all those papers way back in 2019. And they said that the single shot was the most frequently used technique in most of the papers. And the technique is easy to perform, has a low rate of complications, However, despite the effectiveness of the technique, further studies are required. Now, there has been a little controversy with the efficacy of electrospinal block in the last year or so. So we need to keep a watch on how this block will perform itself with regards to long-term outcomes. The other newer block, which has been described by the group in Canada with Dr. Philip Peng and team, is the Peng Block. Now, Peng stands for pericapsular nerve group block and was mainly described for hip fractures. Now, this is again a relatively simple block and does have good benefit when it comes to comparison with risks. So we can see that the anterior inferior iliac spine and the ilium and the pubis and this IPE, which is iliopubic eminence, and the needle is contacted just lateral to the psoas tendon, and then the local anesthetic is injected. Now the needle, when it is given, the injection is given here, what it does is it blocks the nerves which carry supply to the hip joint. Now this is image showing where things are. So anterior inferior iliac spine, then we have the femoral artery, the iliopubic eminence, the psoas tendon, and the target is just underneath the psoas tendon. Now, how do we do this block? The patient generally is a fracture patient, fracture hip. So the initial scan is done over the anterior superior iliac spine, then we drop it down. We get the anterior inferior iliac spine, then we turn the probe, and when we turn the probe, this is what we see. Now, when we perform the block, again, I'm showing from the top, this is the anterior superior iliac spine. Then as we come towards the foot, we will see the anterior inferior iliac spine. That's the anterior inferior iliac spine. And then when we turn the probe, we will be able to see the psoas tendon, and the target will be on the bone, and that's the femoral head. So if you drop it down a little bit, we can see the acetabulum and the femoral head. Now this is again a block being given. So you can see that the needle is coming just at the iliopubic eminence, the psoas tendon here, and the local anesthetic injected to give the Peng block. The other block which we have been using for the past 4 or 5 years regularly for all our knee replacements is the IPAC, which stands for infiltration between popliteal artery and capsule of knee. Now, this is how we give the IPAC, wherein the needle comes from medial to lateral, and it goes between the popliteal artery, as we see here, and the hyperechoic line, which is the capsule of the knee. Now, this is how it's a block wherein we use a volume of around 20 ml, and it blocks a plexus of nerves which rests on the posterior capsule of the knee. Now, this has been found even in literature to give better outcomes with regards to pain relief, and the addition of IPAC and adductor canal block to the local infiltration analgesia which was given improves analgesia and reduces opioid consumption after total knee arthroplasty. Now, local infiltration analgesia is something, again, we are practicing in the last 4 to 5 years, and we inject a mixture of ropivacaine, ketorolac, adrenaline, morphine, and clonidine, and we do predominantly an anterior injection, and this is how the injection is done just before implantation and the various sites at which it's injected. And the efficacy of LIA as a pain management modality is well established now. The components do differ between surgeons, but it is similar most of the times. And anterior only infiltration has shown better results as compared to anterior and posterior infiltration, and also the risk of posterior infiltration, which can cause injury to the popliteal artery, and also shows superior recovery of quadriceps function. Now, finally coming to outcome. Have we made any difference when it comes to regional anesthesia and patient outcome? Yes, we have. Now, this evidence-based analysis, which came out in 2016 in RAPM, looked at whether post-op neurological complications were reduced, whether local anesthetic systemic toxicity was reduced, and hemidiaphragmatic paralysis was reduced, and with regards to pneumothorax. And there were different levels of evidence, but everything pointed towards ultrasound helping regional anesthesia becoming safer. Next, we looked at whether ultrasound is a good alternative for lower extremity blocks. And again, we said that it does decrease block performance time, decrease the block onset time, increase the rate of complete sensory block, and also increase analgesic efficacy. So this review of evidence in 2016 told us that things are looking really good with use of ultrasound. I'm sure we're probably looking at another update coming sooner with regards to evidence. But with regards to ultrasound, again, for use of upper extremity, everything supportive for ultrasound. Now, regarding cancer, we have not seen much of promise, especially with regards to the literature. But we are looking at probably more randomized controlled trials coming in, which will probably point towards an improved outcome with use of regional anesthesia and cancer. The other thing which I deal with quite a lot in my chronic pain practice is chronic post-operative pain. And the role of regional anesthesia is definitely intuitive, but with regards to evidence, we still are gathering evidence. Now, if you look at all the mechanisms and risk factors for chronic post-surgical pain, regional anesthesia has got a role to play in most of them, like peripheral nerve activation, local inflammatory response and neurogenic inflammation, peripheral nerve sensitization, changes in gene expression at a DRG level, central sensitization, descending facilitation. So regional anesthesia does have a role to play when we go by the theoretical knowledge that we have. But because of the multivariate kind of picture of chronic post-surgical pain, it will be difficult to ascertain that one important thing, that is regional anesthesia, can make a huge difference. So we are probably looking at next 4 to 5 years where we might get more evidence pointing towards the benefits of regional anesthesia. Nextly, we've got what do we do with regional anesthesia and make it a success. First thing is we have to think of the patient. Now, we know that it decreases pain, it decreases the opioid-related side effects, which is a very big thing, especially in the US, looking at the epidemic that we have been seeing. It does improve the quality of recovery. With regards to population, again, we are looking at data which are showing that long-term outcomes might be better, especially with the elderly population that we are seeing. Epidemiologically, again, less use of opioids might be helpful for the entire society. And ecologically. Now, why do I say ecological? Because giving general anesthesia does involve a lot of wastage of syringes. It does lead to greenhouse effect, and it is a greener way to probably embrace regional anesthesia because we are using less amount of resources, and also we are not polluting the atmosphere. With regards to healthcare, we have seen an increase in usage of ultrasound across the country and across many hospitals. That is because we know that regional anesthesia adds value. It does have a value in enhanced recovery programs, and regional anesthesia-based clinical pathways are probably the future, especially for certain surgeries which can be done only under regional anesthesia. Then coming to training, we are seeing an increasing access to training. The Academy of Regional Anesthesia runs a fellowship program, and we are having more and more centers recognized across the country, and a lot of our fellows are going on to becoming faculty and training in peripheries and other areas. And coming to training, we should be concentrating on high value blocks, blocks which have less side effects, more value, which can give more surgical anesthesia. And finally, training will improve and ensure quality. Now, this paper did have a slide or a diagram, which I put in the slide, which talked about what could be the high value blocks. Now, interscalene block is definitely something that I would agree with because we can do a lot of surgeries, especially the humerus fractures in elderly, ASA 3 and 4, safely. Axillary block is something which I like a lot. and we use it for a lot of our forearm surgeries and hand surgeries. Femoral nerve block, as you probably are using and are very familiar with for all knee surgeries and many of the lower limb surgeries. Popliteal sciatic block, you can ask anybody who works in a vascular center and they would say this is the block that has saved many lives. So if there's one block which has saved many lives, I would say it is popliteal sciatic, because people who have come close to amputation have been saved by just this block. Then we have the other two blocks, which are the rectus sheath and the rectus spinae, which are mentioned in the high value blocks in this paper. But I'm a little skeptical about that. But we do have to concentrate on these high value blocks in training and learning. So coming to the end of my talk, I would like to leave you again with this slide. And I would like to see how many of you will adopt the regional anesthesia as your primary mode of anesthesia practice, because this graph, as you can see, with the patient access to regional anesthesia increasing and improving across the world, will make a huge difference and huge impact in the way anesthesia is given in the future. Thank you very much.
Thank you, Dr. Muralidhar Thondebhavi. We'll go to question and answer sessions. Any questions in the chat box? So before we go to the question answers, just a reminder of our next week's program. We have Dr. Vinodhan speaking on total parenteral nutrition, and Dr. Anchu on diagnosis of brain death, and Dr. Sedunath R from Kottayam speaking on temperature monitoring in the perioperative settings. Yeah, Dr. Vinodhan K from medical, is a senior faculty in Kerala. He's speaking on TPN and the diagnosis of brain death by Dr. Anchu. She's from Government Medical College Tichur, and temperature monitoring in the perioperative setting by Dr. Sedunath R, Government Medical College Kottayam. So any comments or questions from the chat box? It was an excellent presentation, Dr. Muralidhar.
Thank you. Thanks a lot. I'm sorry I'm not, I'm outside. I'd come to actually moderate another talk, and I'm standing next to the swimming pool taking the questions. I'm sorry I couldn't kind of.
Hey, Rajesh.
Yeah.
I have a doubt to Dr. Muralidhar.
Yes, sir. I can take the question, sir. Yeah.
So when you're given an option for a pain relief in hip between suprainguinal fascia iliac and Peng Block, what is your choice?
Sir, right now, the way things are, we actually had a long discussion in one of our AORA fellowship meetings, and we chose the order of blocks as, the femoral nerve block will be the fastest when it comes to giving pain relief if we have to sit up, the patient for a spinal when the patient is in the operating theater. Now, suprainguinal fascia iliaca block has got a learning curve because we are close to the peritoneum, we are close to the other structures, and unless a person doing the block understands the anatomy very well, it can be a little bit of a risk when it comes to placing a suprainguinal fascia iliaca. Peng block might have a little delay with regards to the onset time, but it is a safe block if practiced in the right way, because the bone will be the end point, and the number of important structures around, especially caudate to the site of injection, is not much. Whereas with the other block, there is definitely a risk of entering the peritoneum and also injuring the vessels. So I would say that if time is of importance, then the femoral nerve block will give actually the best response. A fascia iliaca block, the traditional one below the inguinal ligament, is safe if somebody is doing it without ultrasound or doing it in the emergency room. A suprainguinal fascia iliaca block definitely is a good block, but should be done in with a person who has trained, who knows the anatomy well. And the Peng block is something which is new, but definitely is giving us good results when it comes to doing it for fracture patients.
So one more small question. This
Yes,
fascia iliaca can we use it for surgical anesthesia because it blocks all the 3 divisions of the lumbar plexus? Is it practically useful for that?
The initial description of fascia iliaca was that the drug spread will be proximal. It will go along the psoas muscle and behave like a lumbar plexus block. So even initially when the femoral block was described, it was described as a 3-in-1 block because it blocks all the 3 main components of the lumbar plexus. But it requires, I think, a huge volume, and I don't think it has been used for just a hip surgery. Now, hip surgery also will require, or any surgery around the hip will require even the component of sciatic to be blocked. Now, we know that the lumbar plexus block, when performed, should be complemented with sacral plexus block if we have to do the surgery only under regional anesthesia without a spinal or an epidural. So I do not have any experience of doing any hip surgery only with the fascia iliaca block or any block for that matter. But it can be used to supplement. So it can be used to supplement a general anesthetic technique in high-risk patients, wherein we can get away with very minimal amount of general anesthetic drugs used, and therefore minimize the complications or the side effects on the cardiovascular system.
What about thigh surgeries? Anterior thigh or medial thigh, just drainage
if it is something which doesn't require tourniquet, and also if it is something superficial, then definitely these blocks can be used. Even a femoral nerve block, targeted block will be better than a blind fascia iliaca block. And the femoral nerve block complemented with the lateral cutaneous nerve of the thigh block will be quite helpful. If it's something like a superficial surgery, like a lipoma or something where the patient is at high risk, it can be done only with the block.
What about the medial side, sir? Operator, will it have a significant sensory supply to the medial side of the thigh?
It does. Yeah. So the obturator does have, but it doesn't provide a significant component to the knee joint. So anything which covers the medial aspect of the thigh will definitely be, we'll definitely need to give the obturator block. And I would like to emphasize that whenever you're doing an obturator block, it's better to use a dual guidance technique with a peripheral nerve stimulator, because the obturator nerve is in a plane between the different muscles, the adductor muscles. So therefore, it's better to always use a dual guidance when we are doing an obturator. And that probably is one of the places where I will use a dual guidance for sure when we are doing an obturator nerve block.
Okay, thank you, sir.
Thank you, sir. Thank you.
Thank you, sir, for the excellent presentation. Now, any questions in the chat box? I don't think there is any questions in the chat box. Dr. Murali, your comments about your book, Think Like an Anesthetist.
This is a book that I wrote thanks to the second lockdown. This was something which was on my bucket list for many years. So this is a book wherein I am trying to explain what we do as anesthetists to the general public, and the way we think to make surgeries safe, the way we kind of think to coordinate our time when it comes to either the hospital or our personal time. And also the book is for anesthetists because I have taken a lot of mental models which are applied in various other fields like aviation, and even with regards to finance. There are a lot of mental models. Mental models are the way we understand the world. So the mental model, say, of using an Android phone is different from the mental model of using an iPhone. So the mental models are the way we structure the world in our own mind. So I've used examples of a lot of mental models to explain what we do as anesthetists. It's a short read of around 200 pages, and many of the anesthetists who have read it have given a good feedback so far. So I would like the postgraduates who are listening to this talk to go through the book, which is available both on Amazon as an ebook, which can be downloaded on Kindle, and also as a physical book. Thanks to Dr. Rajesh, Dr. Benil for giving me an opportunity to be a part of this meeting. Thank you.
Thank you, Dr. Murali.
Thank
you, sir. We'll now any comments. If there is no more comments, we'll go to the next talk. We have
Rajesh. Just one question to Dr. Murali. It was
please.
A very well spoken lecture on the recent advances. I just wanted to ask you, Dr. Murali, is why these liposomal drugs are not becoming popular throughout the world? Because, liposomal bupivacaine. So I was thinking that you can do away with these continuous catheter techniques at all. Once you infiltrate the drug, it will be acting for 72 hours. So why these drugs are not becoming popular as such?
Sir, even we were very excited when it came out that, we will be using it in another 4 or 5 years. One is the cost. It's nearly 200 times costlier than the traditional bupivacaine. Now, I do not know how the American system of medicine works, especially with the insurance companies. But there is definitely, I think, the evidence which is coming, especially in the last year or so, is pointing us towards that it's not giving the outcome that they were looking at. So they're not able to get that amount of benefit, especially with regards to opioid sparing, because the Americans now are looking at, they're running away from opioids because of the crisis that they had. So they are looking at how they can avoid opioids, and this hasn't given them the answer. Now, because this hasn't given them the answer and the technology is so expensive, I feel that it probably will not become very popular unless something radical comes up. So I read an interesting article only on the nanotechnology of how they are actually devising these drugs, and it is quite complex. It's a very complex mechanism, which in the way they produce these drugs. So unless the technology changes and it becomes less expensive, I don't think we will see it coming into especially the Indian practice soon.
Thank you. Thank you, Murali.
Thank you, sir. Thank you.
Thank you, sir. Shall we go to the next session?
Just 1 second,
Yeah.
Murali, the book
Yes,
you
sir.
have sent, excellent book. I have gone through that. I did
Thank
not
you, sir.
reply back. I thought I will call you and tell that. And in the introduction only, I told that about your book, and really everybody should read that. Not only anesthetic, I told even my children to read that book. And my wife also interesting that is this what you do that. Yeah.
No, in fact, many people whom have given the book, the children have read, and the fathers and mothers have read the book, and the doctors themselves.
Because we have not told what but they know that what we are doing of reading this book.
Yes, sir. Yes, sir. Thank you, sir. Thank you.
So now we go to the last session of today's academic program. We have our dynamic young anesthesiologist. Dr. Jithin is my good friend and a colleague, and he'll be speaking on Ketamine, an old anesthetic with new horizons. There is a lot of off-label and outside OT applications of ketamine, and to speak on this subject, I invite Dr. Jithin TN. Dr. Jithin.
Thank you very much, sir. I hope my presentation is visible.
Yeah, it's very clear and you're audible.
Thank you, sir. Good evening, one and all. At this outset, I would like to extend my sincere gratitude towards the ISA Kerala State Chapter for giving me this wonderful opportunity to present on this platform. So coming on to my topic, Ketamine, an old anesthetic with new horizons. So for the next 20 to 30 minutes, I'll be enlightening you regarding the novel uses of ketamine. I'll be dealing only with the non-anesthetic uses of ketamine. And you will be actually astonished to know that there are currently more than 800 new clinical trials registered with the US clinicaltrials.gov, and that shows the amount of interest this old anesthetic has regained quite recently. So we'll start with the history. And this molecule was actually discovered by the Park Davis Pharmaceutical Company while they were in a search for a better anesthetic with analgesic property. So they discovered the compounds known as cyclohexylamines, and the first compound discovered was phencyclidine in the year 1956. And in 1962, Calvin Stevens in the Park Davis Company, which is now the company is known as Pfizer, it was discovered in 1962, and the molecule is now known as ketamine. It is called ketamine because it was a combination of ketones and amine. And It was in the year 1965, it was first used in humans after animal studies by Corson and Domino. It got its US FDA approval in the year 1970, and the first major widespread use was in the Vietnam War to treat the wounded US soldiers. In 1985, WHO labeled this drug as an essential medicine, and the next major breakthrough came in 2019, where US FDA approved intranasal ketamine for the treatment of major depressive disorder with treatment-resistant depression. Coming to the basic pharmacology, it's an enantiomeric drug, lipid-soluble phencyclidine derivative, a non-selective, non-competitive inhibitor of NMDA type of glutamate receptors. NMDA is a type of inotropic glutamate receptors. Chemically, ketamine is 2-chlorphenyl 2-methylamino cyclohexanone. So basically, there is a cyclohexanone ring with a chiral carbon atom at C2 with two pure optical isomers, the S plus and R minus. It normally exists as a racemic mixture of S plus and R minus. The anesthetic potency of S plus ketamine is 3 to 4 times that of R minus and 2 times that of the racemic mixture. It is metabolized by the hepatic cytochrome P450, mainly by the CYP3A4 and also by CYP2B6 and CYP2C9 to norketamine, hydroxynorketamine, and dehydroxynorketamine. The CYP2B6 is particularly important because genetic polymorphism have been described, wherein the genetic alterations lead to ketamine's variation in ketamine's plasma concentrations. Ketamine binds to the phencyclidine binding site of the NMDAR type of glutamate receptors and blocks the influx of calcium and sodium. On the left side, you can see the structure of glutamate receptor, NMDA type of glutamate receptor. Basically, it has got 4 components, 2 NR1 subunits and 2 NR2 subunits. So glutamate recognition site is on the extracellular side of the NR2 subunit, and there is a glycine attaching site on the NR1 subunit on the right side. So only if glycine is attached to the NR1 subunit, glutamate can attach to the NR2 subunit. And you can see on the center of the channel pore, there is a magnesium plug which is there. So it blocks any influx of these active ions when the cell is in the resting state. When the cell is depolarized, this magnesium plug is automatically removed and it allows entry of sodium and calcium. The phencyclidine binding site is actually located inside the intracellular part of the NR2 subunit. Ketamine also interacts with other receptors like the opioid, monoaminergic, muscarinic, and nicotinic receptors, ion channels like the L-calcium and voltage-gated sodium channels, modulate some cytokines like the IL-1, 6, 8, 10, and TNF-alpha, also exert some antioxidant properties. The common side effects are post-op nausea, vomiting, increased secretions, emergence reactions, hallucinations, delirium, double vision, and recently the street use of ketamine has led to a syndrome of ulcerative cystitis with contracted bladder with secondary renal injury. It is contraindicated in psychosis, active substance abuse, severe liver dysfunction, significant coronary artery disease, those who have poorly controlled hypertension. So coming to our topic proper, the novel uses. It is used as an antidepressant. It is used for the control of refractory status epilepticus and super-refractory status epilepticus. It is being used to treat pain syndromes, both acute and chronic pain. It is being used as a neuroprotective agent for the treatment of substance abuse. It is also being investigated as an immunomodulatory drug. So the first use as an antidepressant. We all know that the currently available typical antidepressants like the tricyclic antidepressants and SSRI, they take weeks to have their clinical onset of action. While ketamine is a rapid onset action, you can have the clinical antidepressant action as early as 40 minutes, and the duration of action lasts up to 7 to 14 days, which is far beyond its elimination half-life. And on the right side, you can see the Spravato nasal spray formed by the Janssen Pharmaceutical. And this was the drug which was approved in March 2019 by US FDA for the treatment of treatment-resistant depression, not as a monotherapy, but along with an oral antidepressant. And in August 2020, US FDA again gave another approval for this drug to be used in major depressive disorder with suicidal ideation. So we shall examine what is the mechanism of action of ketamine, which constitutes this, which gives this drug the antidepressant action, and why the duration of action is far beyond its elimination half-life. So you can see the label A, where ketamine binds to the NMDAR type of receptors, which are preferentially located in the GABAergic interneurons. As you all know, GABA is the predominant negative inhibitory output to the pyramidal system. So by blocking this GABA interneurons, there is more and more release of excitatory neurotransmitter glutamate onto the postsynaptic membrane. AMPA receptor is another type of ionotropic glutamate receptors. AMPA receptors are located in the postsynaptic membrane of the nerve terminal. So this will activate AMPA receptors. Then again, one protein known as the brain-derived neurotrophic factor is released. It will bind to its receptor known as the TRK beta, and it will signal some downstream pathways which will ultimately constitute synaptic plasticity. So this hypothesis is known as the disinhibition hypothesis. Ketamine preferentially blocks the NMDAR located on the GABAergic inhibitory neurons. So there is a disinhibition, activation of AMPA receptors, release of BDNF, and downstream pathways led to synaptic plasticity and protein synthesis. There is one more hypothesis known as the direct inhibition hypothesis, where ketamine binds to the extrasynaptic NMDAR receptors and it will block glutamate release. It will actually inhibit an enzyme known as the eukaryotic elongation factor 2 kinase enzyme. So there is an excess of EEF2, eukaryotic elongation factor 2, which will again increase the level of BDNF, brain-derived neurotrophic factor, and the mammalian target of rapamycin, mTORC1 pathway, signaling pathways, which finally constitute synaptic plasticity and protein synthesis. There is one more mechanism, that is the authors postulate that it is nothing related to ketamine, but it's metabolite hydroxynorketamine that binds to the AMPA receptors and release BDNF. So basically, whatever be the mechanism, it is the downstream pathways, that is action on the AMPA receptors, release of BDNF, and the ultimate development of synaptic plasticity and certain protein synthesis is important for the mechanism of action, which constitute the antidepressant property of this molecule. Now, there is one more hypothesis known as the Encore D hypothesis. It postulates that ketamine alters the neural encoding, consolidation of synaptic change, and there is a renormalization of the synaptic strength, and all these processes occur during sleep to elicit acute and sustained antidepressant effect. Coming to the review of literature, it was in the year 2000, Berman et al. First described the antidepressant property of ketamine. He studied 7 patients and all of them had a significant but transient improvement with a single dose. 2006, the National Institute of Mental Health did a larger replication of the Berman study using 18 patients, and they also found a successful result. 2013, Rasmussen et al. And 2014, Shiroma et al. Did serial infusions of low-dose ketamine in treatment-resistant depression and found successful results. 2014, Lapidus and Levitek et al. Did RCT of intranasal ketamine. So that might be the first intranasal ketamine study in major depressive disorder. In 2016, J. Berger and Kappa-Bayanko, they tried intranasal ketamine for US military soldiers who had acute suicidal ideation. So they also found a rapid result. There is also a unique utility in treating depression associated with Alzheimer's disease. Ketamine has got some neuroprotection against the soluble beta amyloid protein mediated toxicity. The anti-suicidal properties have also been studied by R.B. Price et al. In 2014. They actually tried a dose of 0.5 mg per kg and improvement occurred within 40 minutes and it lasted up to 10 days. Parsaik et al. In 2015 found out that ketamine treats anhedonia, independent of its depressive symptoms. And Okamoto et al. And Lian Wang et al. In 2017 found out that when used as an anesthetic for electroconvulsive therapy, ketamine decreases Hamilton Depression Rating Scale scores earlier and more significantly than propofol. But in 2017, Li and Shang et al. Found out that the chronic recreational use has shown to produce some cognitive and affective deficits, including depression. So that is a contradictory study. This raises concern regarding its long-term use as an antidepressant drug. It has also found to have some epigenetic effects. Ketamine alters the histone deacetylase in the nucleus accumbens. It alleviates stress-induced depression. So it alters the mitochondrial RNA also, the non-coding RNAs. So these are the trials which led to the US FDA approval of this drug for major depressive disorders. There are 5 phase 3 trials and 2 phase 2 trials. The phase 3 trials were Transform 1, 2, 3 and Sustain 1 and 2. All these used intranasal ketamine in the dose 56 milligram and 84 milligram twice a week. The Transform 1 trial was a fixed dose short-term trial. Participants were in the age group 18 to 65 years. Transform 2 study was a flexible dose short-term trial. Participants again in the age group 18 to 65 years. Transform 3 was a flexible dose study for participants in the age group more than 65 years. In this, Transform 2 yielded positive results. Sustain 1 and 2 were actually withdrawal studies. Actually, Sustain 1 was a randomized withdrawal study and Sustain 2 was a non-randomized trial. Sustain 2 actually studied patients up to 52 weeks from withdrawal of this drug. And there is one more trial which is ongoing, Sustain 3 trial, which actually intends to study the patients up to 5 years after withdrawal of intranasal ketamine, how they relapse and all. So the dosing regimen, IV dosing regimen is 0.5 mg per kg given as an infusion over 40 minutes. Can be repeated 1 to 3 times per week. It should be provided with the ACLS certified providers. The minimum monitoring standard should be continuous pulse oximetry and NIBP cycled every 10 minutes. This I am talking about the IV dosing regimen. Patient can typically get discharged after 2 hours. Well, regarding the intranasal ketamine, it is available as a 28 mg puff. So the treatment can be initiated at a dose of 56 milligram and then continued at 56 to 84 milligram twice weekly through 4 weeks. Mind you, the intranasal bioavailability of ketamine is only 25 to 50%. So even if you give 56 milligram, your bioavailability will be only 28 milligram. The treatment frequency is usually tapered to every 1 to 2 weeks thereafter. The efficacy should be assessed at around 4 weeks and treatment should be discontinued if ineffective. Alternative routes have been tried, like very low dose sublingual ketamine, preservative-free ketamine as inhalation. It has also been studied successfully for the treatment of post-traumatic stress disorder, and 2 RCTs have found out that ketamine is far more superior than midazolam in rapidly reducing PTSD symptoms. Ketamine modifies fear memory expression by having a window of ketamine-induced neuroplasticity. It has also been studied successfully for general anxiety disorder and social anxiety disorder. Now coming to the second use, for the treatment of refractory seizures and super-refractory status epilepticus. By the old definition, status epilepticus is defined as an acute epileptic condition characterized by continuous seizure for at least 30 minutes or by 30 minutes of intermittent seizures without full recovery of consciousness between the seizures. Now, according to the new definition, any seizure lasting longer than 5 minutes is treated as status epilepticus. And persistent SE, despite administration of 2 appropriately selected and dosed parenteral medications, which includes a benzodiazepine, is known as refractory status epilepticus. Actually, there is no specific duration required. Super RSE is an SE that continues at least 24 hours after the onset of anesthesia, either without interruption despite appropriate treatment with anesthesia or recurring while on appropriate anesthetic. An estimated 31 to 43% of patients with SE will finally develop RSE and 10 to 15% of them will develop super RSE. So these two conditions carry significant mortality and morbidity. That is the importance in controlling, in getting an early control in refractory and super refractory status epilepticus. So what is the rationale behind the use of ketamine? Ketamine has shown neuroprotective properties even before it was shown as an anti-seizure agent. And it has also been shown to reduce neuroinflammation. Neuroinflammation is behind the refractoriness of the seizure. Conventional anesthetic agents all act on the GABA-A receptors. But with continued seizure activity, these GABA-A receptors are internalized in clathrin-coated vesicles, and there is actually an upregulation of the NMDA type of receptors, which are moved to the outer surface of the membrane. So only an NMDA antagonist will be successful in treating a continued refractory seizures. Ketamine is the widely available non-competitive inhibitor of non-competitive inhibitor of NMDA receptors. Due to the sympathomimetic action, ketamine is largely devoid of the cardiodepressant properties, and it doesn't lead to airway collapse, so intubation is not always needed. These are some studies which showed ketamine is effective as an anti-seizure agent. Gaspard et al. Did a retrospective study from 1999 to 2012. He found out that 57% it resolved. Rossetti et al. Did study in pediatric age group, and out of the 9 children, 6 children achieved seizure control. Meva Singh et al. Did a study with oral ketamine for the control of non-convulsive status epilepticus. All of the children attained control. Seeler et al. Did a systematic review of 23 studies and found out that it was effective in 56.5% of the adults and 63.5% of pediatric patients. And in this study by Julia Hoffler and Eugene Dringa, they did a retrospective evaluation of all the 26 studies done from 1996 to 2017. And they found out that around 74% of the patients were responders. And this was the first multi-center prospective randomized control, which conducted in 10 Italian hospitals. Study period was 2015 to 2020, and all the participants were pediatric age group. And patients presented with refractory seizures will be treated either in the control arm or in the experimental arm. Those in the control arm will receive the conventional anesthetic agents, and those in the experimental arm will receive ketamine. The ketamine dosage according to the study was an initial bolus of 2 to 3 mg per kg, followed by continuous infusion of 10 mics per kg per minute, and the rate of increase of infusion is by 5 to 10 mics per kg per minute every 10 minutes. Ketamine always administered in association with midazolam. In case of RCSC resolution, the effective dose is continued for a minimum period of 48 hours, and it is gradually discontinued by reducing the starting dose by 25% every 12 hours. The dosage as an anti-epileptic, oral dose is 1 to 2 gram in adults and 1.5 mg per kg in 2 divided doses in children. Bolus, it is a wide dose range, 1 to 5 mg per kg in adults and 2 to 3 mg per kg in children. Infusion, it is 0.45 to 10 milligram per kilogram per hour in adults and 0.6 to 3.6 milligram per kilogram per hour in children. For children, you can actually rely on the Indian Academy of Pediatrics recommended dosage. That is very simple. You give a bolus of 0.5 mg per kg and titrate the dose up by 0.5 mg per kg every 15 to 20 minutes until you get a burst suppression. The usual dose required will be 2 to 3 mg per kg per hour, and the maximum dosage will be 7.5 mg per kg per hour. Ketamine has long known to reduce pain syndromes, both acute pain and chronic pain. Effect on acute pain is mediated by NMDA receptor inhibition and prevention of wind-up. Effect on chronic pain is due to the desensitization of already upregulated NMDA receptors. It can also prevent opioid-related side effects and opioid tolerance. Actually, there is a process known as opioid receptor internalization while you use opioid for a longer time. This is caused by beta-arrestins, and this will lead on to opioid tolerance. But this effect is significantly inhibited if you give a NMDA receptor antagonist pre-treatment. But mind you, subanesthetic doses potentiate opioid analgesia, but it has been shown that anesthetic doses exert antagonistic action at mu and kappa receptors. Leigh Chaperone and S.A. Smith et al. In 2013 did a meta-analysis of all the 40 papers and found out that ketamine significantly reduced chronic pain incidence following certain type of surgeries. Ketamine effectively reduces non-cancer pain, but it is not that much effective in treating cancer pain. Ketamine acts at the level of secondary somatosensory cortex, insula, and anterior cingulate cortex with effective pain processing and decreased allodynia and central sensitization. It has been validated in neuropathic pain, especially the CRPS type 1. 10% ketamine cream applied TID has shown to be effectively treat CRPS pain. Ketamine infusions as an adjunct to gabapentin has also been tried in chronic neuropathic pain in spinal cord injury patients. It has also been found to be effective in treating phantom limb pain and chronic pancreatitis pain. It effectively reduces pain intensity during the vaso-occlusive crisis of sickle cell patients, and its anti-suicidal properties particularly useful in treating chronic pain patients, those who have suicidal ideation. It has also been tried in headache. It has got an important role in triptan non-responders and in those in whom triptans are contraindicated. Intranasal ketamine 25 mg has shown to reduce severity and in some cases the duration of aura associated with migraine. Combination with magnesium sulfate potentiate this effect. But the problem is minimal evidence exists. Several contradictory studies are also there. And repeated uses of ketamine for chronic pain can impair long-term memory. Sensitization and tolerance can also occur. It has also been shown that ketamine is a neuroprotective agent. It is thought to reduce the microglial activation and reduce cytokines TNF and IL-6. It reduces glutamate-induced excitotoxicity. And in the case of infarct, ketamine, low-dose ketamine is responsible for a decrease in infarct volume, edema ratio, and neurologic deficit. Ketamine causes an increase in blood flow both regionally and globally. And in traumatic brain injury, where historically ketamine was contraindicated, has now shown to reduce deficits in dendrites and regulates the autophagic protein production. By historical reasons, ketamine was contraindicated in traumatic brain injury, as the earlier research showed that ketamine increases ICP. But later research have found out that the rise in ICP is mainly due to hypercapnia, which will well be taken care of if you ventilate the patient. So these are the studies which supports the neuroprotective role of ketamine. D.N. Hertel and J.P. Dreyer, they found out that ketamine reduces the occurrence of isoelectric spreading depolarizations that are seen in traumatized human cortex. In human cardiac surgery patients, single-dose ketamine administration at surgery induction has been associated with reduced post-op delirium and cognitive dysfunction. But when you use it for time, when you use larger doses, ketamine has also shown to cause apoptotic cell death and it confers neurotoxicity. So this is a contradictory evidence, and one study has also shown that ketamine counteracts its neurotoxicity by producing a protein known as the activity-dependent neuroprotective protein. And the researchers have postulated that if you pre-treat a low-dose ketamine before giving a large dose anesthetic dose ketamine, that ADNP production is more and it confers some neuroprotective role. It has also been tried in treatment of substance abuse. Ketamine mediates the downstream effects on neuronal connectivity and plasticity through BDNF, and this improves the dopamine signaling, thereby treating drug-related synaptic deficits. It has been tried for alcohol dependence, tried for opioid dependence, cocaine dependence, and heroin dependence with variable success rates. It has also been shown as an anti-inflammatory molecule. DeCock and colleagues opine that it is more of an immunomodulatory drug than an immunosuppressive one. It prevents the exacerbation of local inflammation. The effects are mainly due to inhibition of transcription factor activator protein 1 and NFK beta. It reduces the COX-2 INOS protein and NFK beta binding activity. It also exerts action on NK cells. Chemotactic activity of neutrophils are reduced, reduces expression of toll-like receptors, NFK beta activity, and RAF and RAF cascade. It has also been known to have some anti-tumor actions as well. The miscellaneous uses are, it has been shown as an anti-shivering agent to treat post-op shivering, a low bolus dose 0.2 mg per kg, and as bolus plus infusion 0.2 mg per kg bolus plus 0.1 mg per kg per hour infusion. By vasoconstrictive properties, ketamine reduces the core to peripheral redistribution of heat, and there are also central mechanisms involving modulation of thermoregulation at hypothalamus and locus coeruleus. So it is basically a non-shivering thermogenesis. It has also been known to successfully treat drug-resistant bronchospasm. Goyal and Agarwal in 2013 did a retrospective review of 244 patients and found out that ketamine has a role in status asthmaticus when conventional treatment fails. It has also been tried as an oral rinse for post-op sore throat and radiation-induced mucositis. That's all. Thank you for patient listening.
Thank you, Dr. Jithin, for the excellent presentation. Now, Dr. Jithin, can you take up the questions in the chat box? I think there is only one question from Muthukumar. How is intranasal ketamine useful for anesthetist as pre-medication?
I don't think intranasal ketamine has been approved as an pre-medication. It is only approved as an antidepressant agent according to FDA. And as its role in pre-medication, I don't know. Actually, we use ketamine as a pre-medication agent.
Maybe he's in the context of pediatric patients, but we have better agents like dexmedetomidine, isn't it? Dr. Ramesh has left. Sarah has left.
Dr. Rajesh.
Yeah,
Dr.
sir.
Rajesh.
Yeah,
Dr. Meenakshi Sundaram.
Yes, sir.
Yeah, that question is just like concerned with the pediatric population only, that intranasal ketamine. See, for pediatric, we have given intranasal ketamine, oral ketamine, everything we have given to sedate the baby. As you say, now the newer sedatives are available that can be used. But I want to make a comment about Dr. Jithin's lecture. I want to use 3 adjectives. I am stunned, I am thrilled, I am surprised. Because in spite of being my student, how he has become more knowledgeable, I don't know. He has become more knowledgeable and he is good at delivering the lecture also. Congratulations. Thank you.
Thank you, sir. Always your proud student.
He's very active in ISA, and he and Vijish has brought.
Yeah, I know.
Calicut,
I know. But
award in the national level.
See, in spite of being my student, how he has gained this much of a knowledge, that is peculiar.
Meenakshi Sundaram, that means that you are not imparting all the knowledge